Dr. Wayne Winegarden, thank you so much for joining me today.
Oh, thanks so much for having me. Great to be here.
So we'll start off with something, pretty recent in the headlines. Earlier this week, CMS proposed another physician pay cut for 2027, while proposing a raise for hospital outpatient departments. What does another year of that gap do to a practice weighing an offer?
Yeah, I mean that's just an accumulation of frustration, right? We've been seeing, adjusted for inflation, the payments to physician offices have been going down. They're down what 30%, 31%, whatever the number is, and it every year it makes it harder and harder for independent physician practices to stay viable. Another year is just another year of that. There is the actual financial difficulties of managing that. And then there's the kind of psychological elements of, is this ever going to get better? And so all of that, on the margin, as we economists like to say, is going to just convince more people that, you know what, that's it. I've reached my breaking point and we're done. Exactly how many, that's not knowable per se, but undoubtedly the longer this drags out, the more likely more practices will shut down.
So your brief in PRI earlier this year, we did cover that back in February when it was released. Um, in there, you argue that payment distortions and regulatory favoritism, not ownership structures, are pushing independent practices out. If Medicare had tracked inflation since 2001, how much of that consolidation doesn't actually end up happening?
You know, I think the exact number is one of those things that's not necessarily knowable. What we do know is that the lack of, the declining compensation is a major driving factor. And so if you eliminate a major driving factor, you would imagine that a substantial part of that wouldn't happen, right? There are, from a physician's perspective, right, there are different trade-offs of having your own independent practice versus being part of a hospital system. And as people age and as different, events happen, people will make different choices. And so who knows what the trend would have been in this counterfactual. But the thing we know for certain is if you eliminate that driver, you're not going to have that influence on doctors. And I think that may be the most material point is that if, from a doctor's perspective and a healthcare perspective, consolidating with the hospital is the best way to deliver care, then we want to see it gravitate toward that kind of point of care kind of facilities. What we don't want is kind of unjust government repayment policies putting the finger on the scale, and that's what we're seeing. And so if you adjust that, you would see that kind of ill effect gone, and that's where you get a much better policy environment.
You also argue for site neutral payment and physician pay indexed to inflation. One saves money, one spends money. What's the sequence that gets both of those actually through Congress?
Well, I think the site neutral payment, right, that's sequence is going to be different for the exact reasons you just said. Site neutral gets through because it saves money, right? I mean, the idea that we're paying significantly more money for a service because it was the exact same service was provided in the hospital setting by essentially what is a physician's practice. That it doesn't make sense. It's excessive, So on the cost savings alone, it seems like we can get that passed. When you're talking about physician reimbursement, you are talking about potentially spending more money. But the way I look at it is inflation is a tax. And what you're really doing is you're imposing a higher and higher tax on independent practices by allowing inflation to erode away kind of their compensation for the services. Basic economics says, the more you tax something, the less of something that you get. Kind of going back to the last question. We've been allowing this inflation tax to consistently, impose a higher and higher burden on physicians. We're getting less of it. And so kind of removing that distortion, that is what's happening. Now, I'm an economist, not a kind of politician, not a legislative person. So how do you turn that into the talking points? How do you get the coalition? How do you get that through? I think that's a much more difficult question, and makes it much harder than what you've seen in terms of site neutral payments. But I think where it starts is where doctors are saying, look, we're losing this independent family practice. Patients seem to want that. And so kind of leveraging off of that and leveraging off of the trends, hopefully you can kind of change the kind of the dynamics. The other thing to remember in terms of costs is costs, the whole idea of penny wise, pound foolish types of issues. How do things work out dynamically? And that becomes, I think, a little less uncertain. Again, hospital settings are typically more expensive. If you're spending more but keeping more independent practices open, even with site neutral payments, how do things net out? And when we think things dynamically, probably still cost more, but I'm not sure it's not a bit less than what you would get from kind of just that basic static analysis.
Kind of a simple one, but also sort of a loaded one. How do you define an independent practice?
Yeah, no, it's a loaded one, but it's an important one, right? Especially in light of kind of the research we've been doing, right? In independent practice, I think if you go into the traditional definition, you're talking about a doctor-owned and controlled practice, right? And that's kind of the very tight, and I think most physicians, that is the common definition. So when you now have management service organizations or other types of corporate practice coming in, that is a bit of a hybrid, right? That's not, you're not in a hospital setting, but you're not necessarily a clean independent practice. But I think in some ways that's the beauty of it, right? Because society evolves, our needs evolve, medical technology evolves, kind of the cost, the capital required, all of these things evolve over time. And so now, what is the most efficient way to provide these services so we get the best care at the lowest possible price? And one of the things I think we need to be open to is we don't necessarily know we need experimentation. And so having different forms of delivery, different structures, perhaps they, won't work out, but perhaps we're going to discover a better way of delivering care. And I think broadly speaking, when we talk about overall healthcare costs and quality, we need to allow kind of more of those dynamics to occur so that we're not saying, oh, just a few hundred people in DC or just a few think tank, economists coming up with schemes. We don't know the answers, but if we empower the millions of doctors and other types of health professionals to be able to provide different ways of structuring the delivery of care or different ways of delivering care, that's how we're going to get healthcare costs better under control and increase quality. So I think the kind of the MSOs, whether or not they're exactly an independent practice, that's, again, we're kind of getting into kind of some of the details and some of, but we don't want to get lost, lose the forest for the trees. And so having different structures is a really important way to see how can we deliver better care. And, over time, we'll see what works, what doesn't, keep adapting, and hopefully keep improving. I mean, that's the ultimate goal.
What separates an MSO deal that preserves independence from an acquisition with the paperwork rearranged?
Oh, that's an interesting question. I mean, I think what part of what you're talking about is kind of who has the control over decision making, and I think right separate from preserved independence. Yeah, and there's going to be different structures, and you're seeing more and more laws, and I think that some of these laws at the state level. We've looked at California's as more favorably than something like Oregon, where you want to have the physician in control of the decision making, and that's kind of one of the more important issues I think most patients are going to be kind of more comfortable with. Right, you don't want some bean counter in some desk somewhere in Pennsylvania coming up with a rule when they're kind of being treated in Oregon, California, Minnesota, whatever. So those become kind of very important. But also you would imagine that because that's what patients want, that's where a lot of especially independent practices. That's going to be a bit of a requirement for them. People don't go into medicine because they want to deal with insurance forms, and they don't go into independent practice because they want to adhere to these kind of corporate structures. They want to practice medicine. I mean, that's, it's as much of a calling as it is a career. And so I think you're going to see that having that type of independence is going to be kind of an important kind of aspect to them. Otherwise, why not just go to a hospital system? It's easier. From that perspective, I think you're going to see people more driving toward that physician control over decision making. And I think from the MSO perspective, that is where they're going to find that's how they get value out of it. So that you have kind of like you're saying, where the MSO can provide the capital, it can provide infrastructure, it can deal with a lot of the administrative burden, freeing the doctors up to have a better cost structure and B, spend time on medicine. And that, for right now, again, things will evolve. We'll see where they go, but that seems to be kind of the right balance.
We know a fair amount about what happens to prices when hospitals buy practices. What do we know about what happens when practices affiliate with MSOs?
Well, you see better collections, right? So you're going to see more revenues, and that is part of kind of what's happening. Is you want to see the finances of the practice firmed up, and you do start to see that. You still see prices lower than the prices in the hospital. Some may be higher than what they were as an independent practice. Some may be because they're able to actually collect on payments that the independent practice had trouble getting, and so that's part of the efficiencies. But what you are still seeing, which is really important, is it's another competitive avenue, and so competition in and of itself, that dynamic process over time, we haven't had enough time to see really where things lead to, and that I think will be the really exciting part, is to see kind of as these things, organizations kind of start to get kind of the competition starts to get down. They start really getting into the operations. You're moving into kind of more the medium and long term. We'll start to see all sorts of innovations. But I think what we know for right now is, at least in initial term, they're still priced below where hospitals are. You see some increase in prices from where they were in independent practice, but a lot of that is coming from kind of more efficient billing and other types of collections, which is pretty much part of the justification for being part of that organization.
So you mentioned Oregon briefly earlier. Oregon's law got its first real test this spring, and an independent group used it to fight off an out-of-state staffing firm. I believe that was Eugene Emergency Physicians.
Yeah.
Does that complicate your case against these laws at all?
I don't think so. I mean, I think there's a lot of unique factors in that case. And I think that's part of kind of the process isn't going to be smooth, and we probably don't want it to be smooth. I mean, there's probably issues that we're not thinking through, and this type of conflict brings that to the fore, and we can kind of think through the implications and come up with something better. Yeah, it is, and it is complicated. I mean, I think that's important to recognize that this is not simple, and it shouldn't be, because health is important, and health is complicated, and there's a lot of factors. So no, I mean, I think these are the types of things that we expect to see. Having said that, Oregon has an overly restrictive law. And so I think part of the complications that come into play is because of the overly strict nature, got that word out, of their law compared to kind of some others. Again, I mentioned California earlier, where it's more focused on who's controlling the practice, not kind of the decision making. That is the way to put it. California is focusing on who's making the decision, not who's controlling the practice per se. And I think Oregon kind of goes too far on that, which is one reason why you may see more complications with the Oregon than you would see elsewhere. And again, that becomes a lesson for other states if they're going to pass such laws, that they should look more towards California, not Oregon, as the example.
Corporate practice bans typically exempt hospitals. Why loosen the rules on MSOs rather than extend them to hospital-employed physicians?
For the exact reason we've been talking about. We want to see more competition. We want to see more innovations in how care is delivered. If you extend these rules to hospitals, we're actually reducing competition, right? I mean, we've been talking about hospitals as kind of the big bad competitor, but in actuality, they're an important kind of deliverer of care, not just emergency and inpatient, but also outpatient. And they may have some ideas or ways of delivering care, ways of organizing care. And so perhaps the future of healthcare is going to be much more centered on a hospital because you can get more holistic care there. And so we want that incentive for the hospitals to be very entrepreneurial as well. And if we move more of these regulations and expand them to hospitals, well, now we're just kind of binding them with the same rules. And what we want to be able to do is we want to empower more ideas, not fewer. And that's why we want to remove them off of MSOs, not expand them to hospitals.
So a small primary care practice is getting calls from the local health system and an MSO. Um, what should they ask before signing? And is staying fully independent ever still the right answer?
Yeah, I mean, I'm a policy economist and work in health economics and not necessarily running practices. So I think I'd want to put that caveat out there. Have not run practice, and so if you're running a practice, you probably know much better than me. I think but you're talking about basic decisions in terms of kind of what your quality of life, kind of where you want to go with your patients, your value judgments. I mean, I think those are the types of questions. I think when you look at kind of surveys of physicians, there's a lot of different factors that are kind of impacting them. Do they want to stay independent? And a lot of that deals with quality of life, compensation, how they spend their time, kind of the risks and that they're bearing. And so in these types of restructures, I think those would be the primary issues that they would need to consider. Whether staying fully independent is ever the right answer, absolutely. I mean, right now there's no evidence that a fully independent kind of physician's office is not a preferred way of care. Whether it's for some, all, that's what we're trying to discover. But there's no evidence out there that this is an inefficient way that's like a old blacksmith of old. We just don't need it. I mean, there's just no evidence of that. So now we're coming to kind of in the delivery of medicine, and then we really need to get into healthcare professionals, doctors and nurse practitioners, people who are actually on the ground to kind of determine how do we deliver care best, because they're the ones that are going to know that.
So kind of building off that, taking a look forward, independent practice over the next, let's say, decade. Um, does it survive the next decade? And if it does, what does it look like? Who's left? If it doesn't, what's the thing that finally ends it?
I don't think within the next decade independent practices ends. I think if it does end, it's because of these government kind of practice, the Medicare reimbursement, the regulations. I mean, those are the things that are squeezing independent practices. When you talk to them, those are the things they worry about. Insurance, kind of dealing with all of those factors, the costs involved with that, the lack of scale, right? That's where corporate organizations can help because you can provide that scale to get through all these burdens. So if it doesn't survive, it's going to be because of the accumulation of those burdens. And I say that because that's exactly what independent doctors say when they're, when they either complain or why they sold their practices. But right now, when you look at patients, there are many patients who prefer independent practices. I think we'd want to stay in that, and so we don't have the evidence that that's something that patients don't want. So if that's the case, you would think, well, okay, so that from a demand perspective, right, that is something people want. So now it's just a question: will the bureaucracy overwhelm them? All of them, it's hard to see all of them being overwhelmed by within the next decade. But I think there is this very loud warning siren that's going off that we need to adjust all of these factors that are just overburdening the medical practices. Again, if independent practices are supposed to go away, we want them to go away because it's a better way of delivering care, not because the insurance bureaucracy and the government bureaucracy has overwhelmed them. And so we need to focus on those other factors. How do we bring those costs down so that we can let independent practices, compete and see kind of where it all falls out.
Excellent. All right. Dr. Wayne Winegarden, thank you again so much for taking the time today.
Thanks so much for having me.